I'd like to introduce our speakers today. We have two speakers, Dr. Asamoah and Kelly Jackson. So Kelly Jackson is a licensed and certified genetic counselor with Norton Children's Genetics Center and an assistant professor of pediatrics at the University of Louisville. She obtained her master's in genetic counseling at the University of Pittsburgh Graduate School of Public Health after completing her Bachelor of Arts degree in biology and psychology from WashU in St. Louis. She recently earned her graduate certificate in health professions education through the University of Louisville. She has been involved in metabolic genetics and newborn screening since the beginning of her 27-year career. Dr. Asamoah is a professor of pediatrics and clinical geneticist with Norton Children's Medical Group and the University of Louisville School of Medicine. He completed his residency of pediatrics at Columbia Presbyterian Medical Center and Harlem Hospital in New York, and then did a fellowship in clinical genetics at Harvard Medical School and Boston Children's Hospital. He is a clinical geneticist overseeing confirmatory testing and follow-up of infants with abnormal metabolic newborn screenings for the western half of Kentucky. So I'd like to welcome them, and they will be talking about misconceptions in newborn screening. So I'll turn the floor over to you all.
Good morning, everybody. I'm sorry, good afternoon, everybody. So today we're going to be talking about misconceptions in newborn screening. And so our hope is that this will help our audience understand a little bit about what we're working with when we get a newborn screen and how we help patients that are referred. So as the slide said earlier, we have nothing to disclose, no financial relationships. So our learning objectives today are to review some reasons behind a positive newborn screen that might result in a non-metabolic diagnosis, either for the baby or the mother. We do have situations where both of those things happen. We don't necessarily call it a false positive newborn screen all the time, because sometimes it is positive and something is wrong. It's just not necessarily positive for the genetic metabolic condition that it was screening for. We can go over some of the testing that we do to confirm or rule out the diagnosis and help the audience understand limitations of newborn screening. So just to review a little bit, in case there's any misunderstanding, it's a national public health program, newborn screening, but it's mandated by state law. So each state has its own law that are coordinating and regulating those newborn screens. So there could be different disorders on each state's newborn screen, although there is a recommended panel that we'll talk about. Kentucky, as well as most other states, perform newborn screening by what we call informed descent. So you can opt out of newborn screening if they choose to. But a lot of times parents may not even be aware that it's being performed. There is a brochure they receive, but depending upon their interest, they may not look at that brochure. It's not routinely discussed in the prenatal setting at this point, so a lot of times people are unaware that it's even happening. Some states, like Tennessee, for example, mandate the screen, and people are even penalized if they do not have the screen done before the baby leaves the hospital. So we're doing newborn screening to find newborns who have a serious but treatable disorder. And it's very important to understand that it is a screening test, so it doesn't diagnose, and we do have to do confirmatory tests to figure that out. The newborn screen analyzes specific markers that are indicative of particular disorders, but they're not necessarily only for those disorders. And we'll talk a little bit more about that. And so for metabolic disorders, the newborn screen is looking at the plasma acyl carnitine profile, and they're looking at some of the amino acids that are resulting in amino acid disorders. So until December of 2005, Kentucky was one of the bottom states as far as the number of conditions that we screened for. We had 4 disorders plus hearing loss. But in December of 2005, we were able to expand our newborn screening with tandem mass spectrometry. And now we are one of the top states, the number of disorders that we screen for. So we have about 59 different disorders, and they fall into these categories that you have on the screen there. So we're not going to be able to touch on every single one of these in this meeting today, but I do want to promote that we have a March 3rd symposia. There will be an all-day symposia that you will be touching on most of these. So here's a map of the United States, and you can see the different colors that are representing how many disorders are being screened. So the darkest green is the most disorders, and the lightest yellow are the least number of disorders. So each state has differences based upon their finances and their ability to do testing themselves. And you can see Kentucky is one of the few that we do the most. We actually collaborate with Mayo Medical Center in Minnesota to do some of our testing, just because it was more reasonably priced to do that rather than to bring that part of the testing in-house. We have grant funding, and we do keep up with the recommended panel that's made. So last year, another condition was added to the recommended uniform screening panel called MPS 2 or Hunter syndrome, and we are starting to screen for that very soon. So if you think about newborn screening, you probably think this is pretty rare, but if we combine everything as far as an inborn error of metabolism, we know it's not that rare. It's about 1 in 2,500, which for genetics, that's pretty common. If you add in hearing loss and complex cardiac defects, then we're getting up to about 1 in 500 or more. So that obviously skews it a lot because heart defects are pretty common. We do have the grant funding to screen for all of those conditions that are recommended. So we hope that we can identify quickly these newborns who are to have these rare, serious, treatable disorders. And a lot of times these are not going to be clinically apparent when they're born. Early diagnosis and treatment will help reduce mortality, morbidity, and disability. Most of our conditions have good treatments. A few do not have such great treatments, but they do prevent death and a lot of the morbidity associated, or mortality too. We also want to reduce human, emotional, and financial costs to families. And sometimes on those conditions that are not as well treated, that's the goal, is to get an answer and try to provide the best life possible for that patient. So we have 2 sites in Kentucky that help coordinate whenever there is an abnormal newborn screen. The University of Louisville, now Norton Children's, is responsible for the western half of Kentucky, and then University of Kentucky has the eastern half. Referrals are sent to one or the other of us coordinating centers, depending upon where the patient's birthing hospital is. Sometimes we swap patients if they're border and they end up being in our territory rather than in the other half. We have a newborn screening coordinator who then will contact the primary care provider listed on the screen to ask that primary care provider to call the family and give them a heads up that there's a difference on the newborn screen that we'll be calling to coordinate the follow-up testing. The specific specialists, so genetics or pulmonology or hematology, et cetera, will contact the PCP or the family, depending upon the situation, and coordinate an appointment or a confirmatory testing. And then we would communicate that to the family and to the primary care doctor. Now, every state does this a little differently. And for example, in California, pediatricians are required to do all the confirmatory coordination. In Kentucky, our coordinating centers do that. So to start with the misconceptions, the #1 misconception is this is the PKU test. And although it does screen for PKU, we really prefer you do not call it the PKU test. We've come a long way since we just were able to screen for PKU, and that was started in the 60s. We've had lots of misinformation because it's been called the PKU test. We have a couple of stories. We have that PCP office told the mom, it may have been a nurse or someone in the office told the mom, oh, the PKU test was abnormal. You'll be hearing from the specialist office. And then by the time we call, the mom has already looked up PKU and is devastated and is crying when we call. And we have to tell them, no, the PKU part of the test was fine. It's for something else, and then explain what it is. We've also had a health department once call a pediatrician who was on a screen and say that the baby had an abnormal PKU test, and the pediatrician wasn't sure what to do with this and started looking for PKU specific formula for the baby, eventually called us, and we were able to figure out, obviously, that this wasn't an actual referral, because we would be the ones that would be contacting them, not the health department. It was something that was called equivocal. So they just needed a repeat screen. It wasn't clearly abnormal, and it wasn't even for PKU. It was for a different disorder on the screen. So please encourage your office staff not to call it PKU test. It's not just PKU. The word choices we use when we talk to families really matter. We try to avoid certain words like abnormal. I try to use the word concerning or possible. Sometimes the newborn screen lab will report something as equivocal. It's important to understand that we are not informed about equivocal screens. We do not get those. We do not get involved with those. So those are left to the PCP to coordinate what needs to happen. A lot of times it's just a repeat screen. Sometimes if the baby's in hospital, maybe on TPN or something, it might just be waiting for the baby to get off TPN before repeating the screen. So when we look at our statistics over time in Kentucky, we have about a 1 in 400 rate for true positive newborn screens. So 1 in 400 reported to us as abnormal newborn screens actually become truly positive. The other thing we recommend is if your office is calling that family about the concern on the newborn screen, if you don't have up-to-date information in front of you at the time, because information is changing so frequently and so fast, it's better not to share information that may be out of date concerning the screen, and just relying on us to do that explanation. We've had situations where people are told misinformation, and it's hard to backtrack that once we talk to them. So the vast majority of the conditions on the newborn screen are treatable. There's a couple that the treatment is not great: non-ketotic hyperglycemia and Krabbe disease. There is a treatment available, but it's not very helpful, especially with non-ketotic hyperglycemia. Unfortunately, though, that was mandated by the state legislature, and we're unable to change that. So we do sometimes get those diagnoses, although they're pretty rare. Misconception number 2. Newborn screening is a diagnostic test. And from what I've already said, it's clear that that's not the case. We do confirmatory testing for every single newborn screen that we get. We do not rely on the screening test at all to diagnose. So confirmatory testing may be blood and urine tests, maybe genetic testing, and Dr. Asamoah is going to talk a little bit about some of those tests. More often than not, it's a false alarm, and the child does not have the concern that was raised on the newborn screening. However, when we talk to families, we try to balance the information that we give, because the newborn screen lab has to balance that sensitivity and that specificity. So they're trying to make it as sensitive as possible to detect these treatable conditions and not miss one, but also that lowers the specificity when you do that. So it's a delicate balance that the lab is trying to achieve, and we definitely don't want to miss one of these treatable conditions. We also know that non-genetic conditions can influence the results, and we'll talk a little bit about that. So what are some reasons that we might have a positive newborn screen, but the ultimate result is negative? So babies who are premature, have immature livers, those tend to result in false positives. Babies who are on total parenteral nutrition, TPN, are often getting a false alarm on newborn screen because of the timing of the feeding and the protein that they're getting. Sometimes there are transient conditions that are not truly the genetic metabolic conditions. So we know that there's something called transient tyrosinemia of the newborn, that if we keep following those kiddos and they end up not having tyrosinemia, and they don't have any genetic cause for their elevated tyrosine. That is more often in the premature babies as well. Liver dysfunction in general, if for whatever reason there's something going on with the liver, that can disrupt the metabolism and result in false alarms on the newborn screen. If the baby is a carrier, sometimes the sensitivity level that the lab has set can detect carrier status rather than affected status. So we see that with some of our metabolic conditions, especially where we find that the patient is a carrier, which will not affect their health. But that does allow us to provide carrier testing for other family members and let the family know if they're at increased risk for a child with the actual disease, rather than just to have a child who's a carrier. We also know that maternal metabolic conditions or medical conditions both can affect the baby's newborn screen. Since it's done right after 24 hours of life, Depending on the feeding regimen, we may be getting results that are more reflective of the maternal metabolism rather than the baby's metabolism. And some of the things that we see quite frequently are things like maternal B12 deficiency or carnitine deficiency. We have also found mothers who had a metabolic genetic disease and did not know it. So we've diagnosed a woman in her 30s who had MCAD deficiency, medium chain acyl-CoA dehydrogenase deficiency, had no idea that she had this and was relatively good health. So we've confirmed that for her. We've diagnosed several women with what we call carnitine uptake defect or primary carnitine deficiency. And this has not led to most of them having any significant health issues, although we do recommend treatment because the next time they have a baby, if they're not on treatment, it will result in a false alarm as well. And individuals who have these conditions are at increased risk for heart issues if they don't treat their condition. In the literature, we've also seen moms who have 3-MCC deficiency or glutaric acidemia type 1, and not the baby who's affected. So these are some of the reasons that we have a screen positive, but confirmation negative. So I just mentioned maternal B12 deficiency. This seems to be very common if we go by how many referrals we get. It can present in the infant as an abnormal newborn screen for methylmalonic aciduria, which is a significant organic acidemia. Sometimes it's also reported out as possible homocystinuria. So both of those conditions are serious metabolic conditions that need treatment. And so when we do see a newborn screen that shows elevated MMA, we have to think that it might be that organic acid problem, but it also could be a B12 deficiency. And for whatever reason, the B12 level may not accurately reflect the deficiency. Methylmalonic acid levels in the plasma tend to be more sensitive to what the B12 issue is. So we know that decreased maternal B12 leads to that mild elevation of methylmalonic acid in the mom and even more sometimes in the baby. And long-term, if mom's breastfeeding, for example, exclusively, and she has an untreated B12 deficiency, that baby is not getting it sufficient B12, they will develop symptoms of that, and they can be irreversible in some respects. So it's important that we treat those individuals, that family, that mother and baby, when we find those as well. We do find that moms sometimes have a B12 level that's quote in the normal range. So it's above that 200, 230 cutoff, but it's very low in that range because the range is very wide. And they still have an elevated MMA. So we still treat for a B12 deficiency, even if it's technically in the normal range, just because there's elevations of that methylmalonic acid. Carnitine is a natural substance found in protein. Our body needs that to process fats and to produce energy. It's important to sort of move fatty acids in and out of the mitochondria, which are our energy factories for our cells. If you don't have enough carnitine, it can lead to low muscle tone, muscle weakness, fatigue, and even developmental delay if it goes long term. There are some instances where there's non-metabolic or genetic conditions that lead to a low carnitine level. We know that the carnitine level in pregnancy naturally drops, and sometimes depending on mom's meat and protein intake, it can drop too low, and that leads to the baby having a low carnitine level, and then we trace it back and see that mom's carnitine level is low as well. So we know that if mom has an underlying liver or kidney disease, if she has some malabsorption issues, that can lead to a low carnitine level. Certain medications, valproate, which we hope people aren't on during pregnancy, but if the baby is breastfed exclusively, we need to treat mom and baby for carnitine deficiency. So we are frequently treating the unit and not just the baby to make sure that the mom and the baby get enough carnitine. We have detected in some of these women who had a baby that had a low carnitine that they themselves are carriers for primary carnitine deficiency, but we don't find a second abnormality that's necessary for the diagnosis. So what a speculation is, maybe they have a primary carnitine deficiency and we're not able to detect the second abnormality in that gene. So we do still treat these kiddos even though they do not technically have that metabolic genetic condition. Misconception number 3. Since this child had a normal newborn screen, we know that they couldn't have an inborn error of metabolism. Well, that's not true. We know that this is a screen and we're setting the sensitivity as high as we can, but there is always a possibility that there could be a false negative newborn screen. So it is a screen. If you have a question about a metabolic condition, you should do the testing no matter what. You cannot completely rely on the newborn screen being normal to tell you that the child is okay. So some of the conditions that have been missed traditionally in the past, we know, we have 2 patients with classic homocystinuria due to an enzyme deficiency called cystathionine beta synthase deficiency. The newborn screen relies on elevated methionine, one of our amino acids, to trigger a second tier test that is then, the filter paper is sent to Mayo and they run a second tier test to look at total homocysteine. The challenge is we have to set that level of elevated methionine well enough that we're not sending almost every screen to them, but not so low that we miss some. And we have 2 individuals who were diagnosed, one at 2 and one at 8 with classic homocystinuria after a stroke. So obviously missing these is not ideal. We've also, in the past, you can miss a tyrosinemia type 1 patient. In the past, the marker that was used on the newborn screening was the tyrosine level. And at 24, 25 hours of age, that tyrosine level may not be elevated yet because maternal breastfeeding may not provide sufficient protein to show that elevation yet in the baby. Now we use a different marker called succinyl acetone, or SUAC, and that is much more sensitive. So hopefully we're not missing any of those tyrosinemia type 1 babies. And then we know that milder forms of some of these metabolic conditions may not present with an abnormal newborn screen, especially if there's any issues with feeding or breast milk supply, things like that. So we know we've missed partial biotinidase deficiency patients. Sometimes we do see some of those on newborn screens, but a partial deficiency may not be a significant condition, but it can result in hair and nail growth issues, eczema, mild symptoms. So that's just one example of something we may miss. Thiamine responsive maple syrup urine disease, or MSUD. This is one that we do get referrals quite frequently for young children who smell like maple syrup. And we always have to do our due diligence to rule out MSUD because those that are thiamine responsive forms are milder and they may have been missed on that newborn screen. And then mild ornithine transcarbamylase deficiency, or OTC deficiency, or females with OTC deficiency. So this is a condition that traditionally males are more significantly affected because it's an X-linked condition. We just had a family recently where the new daughter was confirmed after a newborn screen, but their 2-year-old had a completely normal newborn screen. And when we went back and looked, she definitely has the same condition. So those are more likely to be missed on a newborn screen. So anytime you're in doubt about a possible metabolic condition, either refer the patient to a geneticist for evaluation or order those tests yourself to look for that condition. And then misconception number 4, if the newborn screen says that this is a screen positive for condition X, then that's the only condition that child could have. And you may infer from what we've already talked about that that's not the case. So there's some labs that Dr. Asamoah is going to show you that the newborn screen was positive for glutaric acidemia type 2. In reality, she had a mitochondrial disorder, which the labs overlap with what it looks like. We've had another baby who was said to possibly have CPT2 deficiency on newborn screening, but we detected a different enzyme problem related to carnitine called CACT deficiency. And then we've had one baby that had an abnormal newborn screen for MCAD, and eventually it was determined that that baby had trifunctional protein deficiency, which is extremely rare. So if we relied only on what the screen tells us and only rule that out, then we may miss some of these things. So most of the time our confirmatory testing is broad enough to detect things similar or overlapping to those conditions that the screen discussed. So now I'm going to turn it over to Dr. Asamoah to talk about some results.
Good afternoon. Yeah, we'll go over some of the examples of screen results, some of the confirmatory testing that we found, and at the end, we'll probably have a couple of cases that we'll probably ask people to try and see whether they can figure out what the condition is.
The down button on this keyboard.
So this is a kid who we saw, and of course, at times newborn screen may point to a diagnosis of possible MCAD or maybe one of the fatty acid oxidation defects. And of course, when we did the acyl carnitine profile, if you see, it says that the C2 carnitine was mildly elevated. In EPIC system, whenever there's a value that is a little bit off, it flags it as abnormal. So again, seeing a flagged value does not necessarily mean that the confirmatory testing is positive. In fact, the most important thing is to look at the bottom and the interpretation of the results. And if you look at this, again, C2 is acetylcarnitine was elevated, but the laboratory, the interpretation is normal. The people who are doing the testing, they are experts in the biochemical genetics testing. So again, we rely on them for their interpretation. So the fact that something has been flagged as abnormal does not necessarily mean that the test is positive for anything. You have to look at the final interpretation to help you decide whether what you are dealing with is a positive test or not. And in this situation, the acyl carnitine profile was normal. There's another acyl carnitine profile. This one is acyl glycines. Again, here we are looking at the urine. Whenever we see a child and we suspecting either some organic acid disorder or fatty acid oxidation defects, in addition to getting urine organic acids, acyl carnitine profile, at times we get acyl glycines as well. And if you look at it, again, they are flagging propranolol glycine and suberyl glycine and also diodic, one of those other glycines. Again, it looks like they are mildly elevated, but it doesn't seem to point to any specific diagnosis. And if you look at the interpretation, the acyl glycines is interpreted as normal. So finding minor elevations in some of these analyzed do not necessarily mean that the patient has any specific condition. Because I mean, again, if you sample many of us, you run this specimen, you are going to see variations in some of those numbers, but they may not necessarily mean that we have any of those conditions. So again, whenever you are looking at the laboratory test, look at the interpretation. That is the most important part that I want to emphasize. Look at what the laboratory, the folks who are doing the testing say. If they say it's normal, there's no point wasting your time thinking that, oh, there are minor variations, so it means something. So there's a newborn who initially presented with severe lactic acidosis and of course metabolic acidosis with increased anion gap. And of course the newborn screen, this was the result that they found. They realized that there were several analytes that were kind of elevated, and these findings were suggestive of glutaric acidemia type 2. Glutaric acidemia type 2 is a fatty acid oxidation defect, and the genes function in the mitochondria. These are electron transport flavoproteins, and mutations in this gene cause this particular condition. And so, of course, the newborn screen was abnormal for this condition. But then prior to we getting the newborn screen result, because of the severe acidosis, including the lactic acidosis, we sent blood to a different laboratory for genetic testing. We call it mitochondria, cellular energetic testing. And of course, we found some results. Prior to that, we had sent confirmatory testing for acylcarnitine profile, and you could see that several of the analytes are elevated. And so again, based on this elevation, the biochemical laboratory felt these findings are consistent with glutaric acidemia type 2. Of course, over time, the acylcarnitine profile kind of changed. So the findings that we were getting with serial testing didn't really point to any specific diagnosis as such. But again, the organic acids on this kid again was pointing to the same diagnosis of GA type 2. But then the gene testing, in fact, this showed that this patient has a mitochondrial disorder. The gene is called LRPPRC. It's a kind of a nuclear gene disorder that affects mitochondrial function. And it's possible that because the GA type 2 genes are in the mitochondria, they function in the electron transport chain. Probably this gene affect the electron transport process. And that's why maybe biochemically it looked more like a GA type 2, but in fact, in actual fact, this child had a nuclear mitochondrial disorder. So again, these are situations where you see an abnormal newborn screen and you get some confirmatory testing may point to some diagnosis. Then you go ahead and do gene panels and they tell you that indeed this is what the patient has, rather than what the biochemical lab was thinking was the case. So again, testing, in-depth testing probably might help unravel some of the conditions that we'll be dealing with, rather than not knowing what we are dealing with. So this is a situation where the patient was called out as having a carnitine deficiency. This is a newborn screen result. So if you look at the fatty acid disorders line, you could see that the C0 carnitine was kind of low. The reference range was between 5 to 65, and these patients are 3.9, which was flagged as abnormal. And then, of course, we did the acylcarnitine profile, and on the acylcarnitine profile, they look at the free carnitine as well, and the free carnitine was markedly reduced. The reference range for that age was between 15 to 55, and this kid had a very low value. Most of the carnitine was bound to some compound. So if you look at the ratio of the what they call the esterified form to the free form, it was kind of elevated. And again, you look at the acylcarnitine interpretation, the findings were kind of suggestive about that CPT2. CPT means carnitine palmitoyl transferase deficiency. It's one of those enzymes important in the beta oxidation of fatty acids in the mitochondria. And of course, so the question was whether we are dealing with CPT2 versus CACT. CACT is acylcarnitine translocase deficiency. And we went ahead and did the gene testing, and indeed this child had a CACT pathogenic variants. He had two of the variants. This is an autosomal recessive condition, meaning each parent was a carrier and they pass on the non-working gene to this child, and this child had a 1 in 4 chance, and indeed he was affected. So again, this is a situation where newborn screening was pointing to a certain diagnosis. Confirmatory testing, we're looking at 2 possible diagnoses. Then we use the gene testing panel to kind of sort things out, and we came up with a final diagnosis of CACT deficiency. So again, the point here is that newborn screening is a screening test. And so whenever we see an abnormal, what do you call it, an abnormal screen, it means we want to do more testing to figure out what the situation is. And as Kelly said, for the most part, the test may end up coming back negative, but at times we may have to do more testing to really come up with a final diagnosis. So with that said, I will probably put this question, the case scenario there for you all. Do you all see the case?
Yes.
Yeah, so you can look at the case and tell me what you think the right answer is by polling. So it's like maybe like a Friday and you receive a call from the newborn screening lab that the baby did have an abnormal screen indicating that the screen was pointing to the fact that this kid had a C5OH acylcarnitine that was elevated. So you were thinking about a possible organic acid disorder. Of course, you follow this family for some time. You follow some of their kids, and they are all well. The woman is somebody you can trust. The baby is feeling well. It's not in any distress. And so the question is, what do you do in this situation on a Friday afternoon?
Oh, there's your results.
So can I click close or maybe not?
No, just talk
okay.
about them.
Yeah, so it looks like it's kind of the distribution is rather kind of more like a bell curve here, more or less. Majority are saying that you want to see the patient on a Monday morning. This is the screen was reported to you on Friday, and majority are saying they want to see the patient on Monday. Some are saying refer to the metabolic center. Others who are saying to the emergency room, and a few are saying blood drawing center tomorrow for and on, and then finally to your office tomorrow. And then there's a kid who, and the answer is B. Send the kid to the emergency room immediately for blood work and clinical evaluation. The reasoning here is that there's a kid who potentially could have an organic acid disorder, and children with organic acid disorder may appear normal to you at this point in time, but you never know when they are going to decompensate. And since you don't know that, even if there's a family that you trust, you also want to send a child to the emergency room so that at least somebody can take a look. Probably they can get ammonia, they can get blood chemistry to make sure there's no metabolic acidosis with increased anion gap. And then of course we can then go ahead and do the confirmatory testing. But you don't wait till Monday because this kid may crash before Monday, or you don't wait till tomorrow because again, you never know whether this kid is going to crash overnight or not. And when these kids crash and ammonia goes up, at times you may have to resort to very invasive procedures like ECMO or dialysis to get ammonia down. So you don't want to wait. You want to be able to catch them in good enough time and institute the necessary treatment before they decompensate. Any questions on that? Okay, let's look at the next case. It's
Just to the down arrow.
which one?
Or you have to click the mouse on the screen,
Oh, this one.
on the other screen.
Which one here?
Yeah. There you go.
Oh, okay. And this is another case scenario that was reported to your office. The newborn screen laboratory called the office that a 1 week old has elevated phenylalanine. Review of the infant record revealed that the infant was in the office a few days prior. And the mother said that the kid is feeding well. The physical exam when you saw was normal. So your next step in managing this patient will be, and you can choose.
Oh, yeah.
Okay. It looks like majority says begin the infant on low phenylalanine formula. And then, of course, a few we're talking about some were saying switch to soy, and the others say other amino acids, and of course, a few says other urine for terran metabolites. The answer is D, other plasma amino acids. The point is that this is a screening test. And so again, you don't know whether indeed this is a false positive or not. So you don't just go ahead and switch to a low phenylalanine formula. You want to do the confirmatory test by getting your plasma amino acids. Back to switching to soy formula, we use that for galactosemia, not for PKU. If you are suspecting galactosemia or the screen was positive for galactosemia, yes, you want to switch to soy formula until you get your confirmatory testing back. And of course, if it's come back normal, you can go back to normal formula. But yes, soy is for galactosemia, not for PKU. Urine for the terran and then the enzyme. Yes, we do the testing, but those are rare causes of PKU. So the mainstay of testing is in general the plasma amino acids. The first thing we want to do, we go ahead and do the terran metabolites and the enzyme, but yes, we want to look at the amino acids to make sure that indeed the Phe level is elevated before we start treatment. And one thing about PKU is that it's one of those conditions that you have some wiggle room. The teaching is that if you start the diet before 3-4 weeks of age, then you get the best outcome. And so clearly, for a 1 week old who has a positive screen, we still have some wiggle room to go ahead and do the confirmatory testing. And if we draw the blood, we'll get the result back within maximum 7 days. Most of the times, we're able to get them back within 3 or 4 days to know whether indeed the patient has it or not. And if indeed the patient has it, that's the time that we want to put the kid on low phenylalanine formula. We've gotten situations where the patient screened positive, and then we tested them, and it called the test came back normal. So again, if you hear about a positive screen for PKU, you don't switch the diet. You want to do the confirmatory testing first before you decide what to do. So I was probably switch with Kelly to take over the take-home messages about the newborn screen.
So just to remind everyone about those misconceptions, please call this the newborn screen test, not a PKU test, just to avoid any confusion for our families. Remember that it is a screening test. It requires further testing, and we prefer that testing to be done before treatment starts. There are a couple exceptions. As Dr. Asamoah mentioned, in galactosemia, we do switch to a soy-based formula. We do prefer, if possible, to get those confirmatory labs first, because we do want to see how much of the galactose 1-phosphate has built up in the system. But if the labs are delayed, it's better to go ahead and switch to soy to avoid problems. In the fatty acid oxidation disorders, the main treatment is avoidance of fasting. So we do recommend that from the beginning of getting that newborn screen back, because it's not going to impact our confirmatory testing, and it can only help And most babies in that first week or two of life are going to not sleep more than 4 hours anyway. It's important that the baby see a provider as soon as possible. We do document in the lab. Follow-up team wants us to document when the baby sees a doctor, just to make sure someone's laid eyes on that baby and the baby's doing fine. And we also want to get those confirmatory studies done as soon as we can, get them started as soon as we can. We try to work with families who are far away, that maybe they don't have to travel into Louisville for labs, but it just depends on their location and the hospital lab that's nearest, and how willing they are to work with us to get these sent to the labs, the lab reference labs that can do them expedited. If a newborn screen raises a concern for one of those organic acid disorders or the urea cycle disorders, these are the ones that can be very life-threatening in a very quick turnaround time. So they're high risk for acute crises in those first few days of life. So sometimes we do bring them into Louisville no matter what, to get those labs done and seen in the ER to make sure they're fine. Lastly, a newborn screen can point to one particular condition, but it might be a different disorder that's diagnosed, including undiagnosed maternal condition or dietary differences for mom. So we are happy to take any questions that you all might have at this point.
All right, thank you all. That was good. A couple questions. So what are some good resources for people listening to utilize to learn more about newborn screening?
So we always recommend physician offices use the American College of Medical Genetics, have what we call ACT sheets. So these are things that are readily available. If you Google ACT sheets, ACMG, you'll find them. And they also include a parent fact sheet that you can give to the families so that they can have something in hand. But we also want to promote, we're doing a full day symposium on March 3rd. The registration is in the comment section. So we're going to be talking all day about newborn screening and focusing on those individual groups of conditions and maybe a little bit about the future of newborn screening. So feel free to register for that. It'll be live streamed like this as well.
Okay, and then what are some causes of false positive newborn screens?
So as we said before, prematurity is one of the more common reasons that we have a false positive, or if the baby's not feeding on formula or breast milk, but on like TPN or, and then those maternal conditions can really impact. So vegetarians, moms who are vegetarians are at higher risk for either the maternal B12 deficiency or the carnitine deficiency or both. We've seen both in some women. So just things to think about. And other times we don't understand why it was a false positive. We know that the heat, in the old days, the newborn screen cards would be mailed in the mail, and in the summertime, we would have a lot more referrals for enzyme related deficiencies like galactosemia or biotinidase, because that heat degrades that enzyme on the filter paper. Luckily now the lab pays for a courier service to pick up the newborn screen cards and deliver them the same day to the lab. So we have lowered the false alarms for that reason, for the heat. But if maybe they're sitting around extra time, then that can also lead to some false positives.
Okay.
And also in terms of the blood spots, I think they advise that you drop just a spot. You don't have to layer it, so that if there is some layering, that's when they were trying to do the hair stick, there's so much layering. If they do the punch and take a specimen from that, you are more likely to, like for PKU, for instance, to get a higher value from the layered spots, so that when we do the confirmatory testing to come back normal. And in general, with PKU, the cut point is 2 milligrams per deciliter. So anything 2 milligrams per deciliter or above is flagged as positive. So if there's layering, it can affect those things. So we really want to make sure that they make sure they don't just keep dropping and layering it.
Okay. And then it looks like at the beginning, our state tests pretty extensively on newborn screening.
Yes.
What's the next disease that we need to screen for in the newborn period that isn't on our current
I think they are talking about
Duchenne.
Hunter syndrome, which may be on so far. It is in the
Pilot study.
pilot state. So I think very soon it may come on. I'm not sure about Duchenne muscular dystrophy. That some people are talking about it. So maybe at some point it may also come on the screen.
And then who controls how it gets put on the screen?
There's a committee called RASP. I mean, Kelly can talk to you about that.
Yeah, so there's a committee that meets and looks at evidence for the conditions, and support groups and families can actually recommend a certain condition, and then the experts will review the evidence to see, is it treatable? Can we detect it? Is it something that is going to reduce morbidity and mortality? You know, does a lab have a mechanism to do that? And so they are meeting regularly and they're adding conditions frequently. We also know that there's probably about 60 genetic conditions that are in gene therapy trials. So the future outlook is that anything that can be treated with gene therapy may have the opportunity to be added to the newborn screen. Obviously, we'd have to do more genetic testing as part of the newborn screen, not just the metabolic testing, but the sky is the limit so far. We may have a lot of things added to the newborn screen over time.
And then are you all on that committee?
No, it's a national committee,
National.
experts in the field.
That field, yeah.
Mhm.
Okay. And so then each state looks at the national committee recommendations and
That's
decides.
right. That's right.
Okay. And then who's on our state committee?
Kelly is on. I kind of jump in back and forth because of clinic schedule. And of course, the folks at UK, most of the people are from the UK, and here is Kelly, who is the main person.
And we have a representative from each subspecialty, so hematology, endocrinology, all of those that we meet regularly to talk about the future and what we're doing and improving the quality of what we're doing right now.
Okay. All right. Thanks, you guys. That was very interesting.